Welcome, everyone. Good morning. It's my pleasure to welcome Dr. Panos Christakis and his resident team of Seema Mami and Ryan Mason to Grand Rounds today. So Panos did both his undergraduate and medical degree at Yale University, and then joined us in Toronto for his residency, where he was the co-winner of the Workup for highest academic standing. Well done for that, Panos. He went on to do his medical retina fellowship at the National Institutes of Health in Bethesda, Maryland, and he now practices full-time at KEI, and he chairs, very important duty, our examination committee for residents. So welcome, Panos and group. We're excited to hear what you have to talk to us about this morning.
Thank you very much. So for the people that didn't hear, we're going to be doing some case presentations. We're going to try and make this, it's a bit harder to make it interactive with, through Zoom, but if anybody has any questions, you could just post them through the chat, and we'll be taking questions throughout both presentations. So we'll start with Seema Mami, who's an all-star PGY4 in our residency program, who will be presenting a series of cases.
Okay, good morning, everyone. Are my slides playing? Perfect.
Yeah.
Okay, so good morning. My name's Seema. If we haven't met before, I'm one of the PGY4 residents, and I was really lucky to work with Dr. Christakis on this presentation. Oh, there we go. And we're going to present a couple of interesting Masquerade cases for your, and we'd love to hear your thoughts. And we thought this was very appropriate as we're coming up on Halloween. So without further ado, we'll jump into our first case. We met in the emergency department a 37-year-old female who came into the emergency department because of bilateral vision loss. She first started having blurred vision in the right eye, and then today, on the day of presentation, she noticed decrease in her left eye vision as well and came in. According to the emergency room doctor, this vision loss was painful and associated with photophobia. They were able to elicit a history of oral cold sores, and based on their emergency room examination, referred the patient for consideration of herpes simplex virus keratitis. There was no significant ocular or medical history to report, but her social history was significant for having no fixed address and previous intravenous drug use, although she had been on methadone for the past 5 years. So she came up to the eye clinic and had quite striking findings right away. So her visual acuity was strikingly decreased, worse in the right eye than in the left, but she was only counting fingers in both eyes. Intraocular pressures were normal, and her pupil exam was significant for minimally reactive pupils in both eyes with a fixed left pupil, but no reverse RAPD on testing. Her slit lamp examination was quite symmetric, and you can see some of the details here in this picture on the left. So in both eyes, she had a mild perilimbal injection of the conjunctiva, but most strikingly, she had limbus to limbus, greasy, pigmented mutton fat keratic precipitates spanning the entire cornea. In the anterior chamber, it was relatively difficult to see because there was significant flare. However, there was some cell as well as fibrin deposits in both eyes, and there were dense posterior synechia of both irises. There was a very poor view to the fundus in both eyes with really a minimal kind of view at all. And so a B scan was performed, which showed a mild grade vitritis, but the retina was flat in both eyes and no intraocular mass was seen. The sclera and choroid were also normal. This was essentially the extent of the examination that the resident was able to perform. So with this in mind, I'll jump into our first question just to see what everybody is thinking. When faced with this patient, which causative etiology are you most suspicious of? Would you think that this is an infectious process, an inflammatory process? Are you suspicious for trauma, or is that just not really enough information at this point and you're unsure? So it looks like this up and down. So we've got a little bit of a split. About half of us think that there's an infectious process, about just over a third think inflammatory, and some people don't quite have enough information to make a decision at this point. Okay, so I think this is shared. We'll move on to our second question just to see, at this point, again, based on this examination, which empiric therapy would you consider prescribing for this patient? First option is valacyclovir 1 gram PO 3 times a day. Would you consider injecting intravitreal ganciclovir to both eyes? Would you prescribe oral antibiotics, moxifloxacin? Would you start with topical steroids, so difluprednate, 1 drop to both eyes every 2 hours? Or at this point, again, is there not enough information and you prefer to observe until there's more information available? I'm going to give this just a few more seconds here because there are some changes. Okay. So it seems that there's, again, a split. So about a third would start with antiviral oral therapy, a third would start with just topical steroids, and 43% would just wait until there's a little bit more information. So before I jump into what we did here, I think it's important to review the differential diagnosis when you are faced with a patient who has bilateral granulomatous anterior uveitis, as that patient has here. And in fact, this list is quite short. So really, you can think about this in terms of infectious and inflammatory causes. In the infectious camp, there are significant diseases that must be considered, including tuberculosis, syphilis, leprosy, as well as herpetic viruses and parasitic viruses, such as toxoplasmosis. With regards to inflammatory diseases, sarcoidosis, Vkh have been contenders, but you also have to be suspicious for sympathetic ophthalmia, particularly if there's been a history of trauma, and phacoanaphylaxis can present bilaterally as well. So a good history is necessary. So with that in mind, we did, of course, this is a Uveitis retina presentation. So of course, we did a good review of symptoms. This patient was born in Canada. She hadn't traveled, just like most of us at this point. But of course, she was unhoused and sleeping outside. Systemically, she reported that she was well, no joint pain, respiratory illnesses, no constitutional symptoms. And she did have a history of cold sores and previous chickenpox infection as elicited by the emergency room doc. She had a history of intravenous drug use and was currently using methamphetamine and methadone. And she endorsed having a previous HIV positive sexual partner, but did not have a history of sexually transmitted infections herself, as far as she knew. Given her review of symptoms and the differential diagnosis that we've gone through, we know that a differential diagnosis is not overly broad. However, there are some things that must be considered when you're faced with a patient who has such significant vision loss in the presentation that she did. You must always think about vision-threatening etiologies that are difficult to reverse, especially when you have a patient with a severe anterior uveitis and no fundus view. This essentially boils down to, you must think about things like viral retinitis, especially when you're faced with a patient of cold sores and chickenpox, because this can be a devastating illness with no real recourse. So with that in mind, we actually started this patient empirically on valacyclovir orally on the day that we met her, and also prescribed topical prednisolone Q2 hours and atropine to try to control the anterior inflammation. As we discharged her from the clinic that day, we also sent her for a uveitis workup. So this included a CBC and metabolic panel, inflammatory markers such as ESR, CRP, and ANA, as well as ACE to test for sarcoid. In terms of serology, we sent off for HSV and VZV, as well as syphilis, HIV, and given that we were ordering those tests, also recommended STI screening to be performed by her family physician, and performed a chest X-ray to look for signs of tuberculosis and sarcoidosis.
One quick comment here was just based on the poll, a lot of people said that they would observe until more information was found. And I've noticed that when infectious processes are thought of, people are oftentimes reluctant to start treatment until receiving back the infectious workup. With uveitis, oftentimes the complications are as a result of inflammation. And so even if you suspect an infectious etiology, it's always okay to start your usual topical steroids and cycloplegia, because oftentimes these patients get into trouble with posterior synechii, secondary pupil block, iris bombay, things like that. So it's always okay, even if you suspect an infectious etiology, to start topical steroids as well as cycloplegia. Now, the one exception is if you think that there might be a herpetic condition. When you're starting these topical steroids, it's prudent to start antivirals as well, so that you don't elicit like a herpetic epithelial disease. In this particular case with bilateral, a bilateral granulomatous uveitis, viral is definitely on the differential. Bilateral is a little bit more unusual, but definitely can occur. Given that the antivirals are very well tolerated, it's always reasonable to start them empirically, especially if you have no view to the fundus. I do remember one case that I had last year of a patient who presented like this with bilateral panuveitis and had bilateral acute retinal necrosis due to VZV. So the view was very difficult the first few days because of synechiae, but he was started on empiric Valtrex, which proved helpful later on. In this case, also an anterior chamber paracentesis for viral PCR would be very helpful, but the patient declined. So that's why that wasn't done. But in this particular case, it would be something worth considering, especially given the degree of vision loss and where any kind of delay in diagnosis may affect their outcome.
Thank you, Panos. I think that leads us really well into our next slide, which is 2 days later, the patient returned. There was essentially a stable examination. The vision was fairly similar. There was a mild improvement in the AC reaction. And you can see that there was some view to the fundus, which did not show any obvious retinitis. So my question here becomes, with this presentation 2 days later, with positive serology now for HSV1 and 2, would this change your management? And I think in order to answer this question, we have to actually look at what does a positive HSV serology really kind of mean in the context of Ontario. Well, in Ontario, as you can see here on the chart to the left, if you look at all the different health regions in adults, especially where we live in the Central West region, over 2/3 of adults have positive antibodies to HSV1 and about 10% have HSV2. But if you break it down by age 45, about 90% of adults will have demonstrate evidence of previous exposure to HSV1 and 20% will demonstrate antibodies to HSV2. So, you know, in practical matters, this means that the presence of HSV antibodies can have a high specificity but a low sensitivity for infection, meaning that if somebody does not show presence of previous exposure, you can likely rule out HSV-related uveitis. But the presence of antibodies alone cannot confirm or diagnose a HSV-related uveitis. So this simply means that in our patient, we must maintain a broad differential diagnosis. This could very well be HSV diagnosis, but it is not enough to fully clinch our diagnosis.
And the one caveat to that is if somebody has a primary HSV, so they may be IgG negative, but IgM positive, and there's a little bit of a lapse between presentation of symptoms. So if they're negative, but you still have a very, very high index of suspicion for a viral etiology, it's obviously still worth doing kind of an AC tap. Now, we do have a question here from Alex Kaplan saying, if no view to the back and no history of cold traumas, would you still performed an AC tap? And the answer for me is yes, because it could also be VZV. So patients with, you know, first of all, people could have HSV without having had symptoms in the past. And secondly, most of us have been exposed and had chickenpox as children. And so you could always get reactivation. And that's usually the most kind of common cause of BARN is varicella zoster. And it could be quite aggressive, like the patient I discussed before. So I would have still done an AC tap. And at the end of the talk, we'll talk a little bit more about in which cases I personally would recommend doing an anterior chamber tap. And I'd be interested to hear about Alex as well, because I know he's done a lot of research on the topic. Okay, go ahead, Seema.
So we did continue the empiric antiviral therapy in this patient, again, maintaining a broad differential diagnosis. But several days later, the rest of her investigations came back, and it was clear that her syphilis serology was positive with an RPR titer of 1 in 64, which we'll discuss the implications of that. And as well, unfortunately, we got a positive HIV serology. So taking this together, we were able to diagnose the patient with a severe bilateral anterior uveitis with panuveitis secondary to acute syphilis infection. Before we jump back and talk more about this case, I'd like to discuss ocular syphilis. So syphilis is a disease that we all hear about, not only in medical school, but of course it's part of the kind of common vernacular. And syphilis is a bacterial infection that's caused by a gram-negative spirochete. It's transmitted via direct contact with infected individuals, commonly via through sexual contact, but there is potential for maternal fetal vertical transmission as well during pregnancy. Syphilis typically is classified in 3 stages that are based on the amount of time since exposure, although it is possible to have very late syphilis as well. The first stage occurs within the first 3 months of exposure and is associated often with a chancre sore. The second stage is often associated with a full body, a body maculopapular rash, which happens in the first 4 to 10 weeks. And finally, more prolonged infection can result in what's known as gamma, or infections of the internal organs. Ocular syphilis, however, can occur at any stage, but most commonly it is documented during secondary syphilis. And it is often considered a subset of neurosyphilis. And it's important to know that in patients who have an acute syphilitic ocular complaint, they can have symptomatic or asymptomatic CSF derangements with direct infection of the cerebrospinal fluid as well. So they may present with neurologic symptoms in addition to their eye findings. Syphilis has been around for a very long time and is commonly known as the Great Masquerader. There's clear evidence of syphilis since the 1400s, but some historians think that it's been around since before the Common Era as well. And it can truly affect any ocular structure, from the eyelids with a chancre sore to conjunctiva. There are multiple presentations of keratitis, uveitis of the anterior segment. There can be gamma of the iris and ciliary body. And in the posterior segment, you can have vasculitis, chorioretinitis, retinal detachments. And for the back of the optic nerve, you can get an optic neuritis or atrophy. And syphilis can also affect the brain, resulting in cranial nerve deficits, pupil abnormalities, strokes, cortical visual impairment, and resultant visual field defects. So it really is the great masquerader, and almost any ocular presentation includes syphilis on the differential diagnosis. How do we test for syphilis? Well, unlike some other infectious diseases, syphilis cannot be cultured. And you can actually only see it directly under the microscope if there is a very high spirochete load. So for example, in a gamma. In Ontario, the current testing algorithm involves 3 steps. So the first step, an immunoassay is performed, an enzyme immunoassay that looks for IgG and IgM exposure. This has a high specificity, but it cannot differentiate between acute and chronic infection, or more infection in the distant past. If there is a positive IgG or IgM, a non-treponemal specific immunoassay is performed, and this is something like the rapid plasma reagent, or an RPR. This has high sensitivity and also has the benefit of providing quantitative titers. In this case, the higher the number, the more essentially the higher concentration of syphilis disease that is being found. And these titers can be followed to see that they decrease as a patient's being treated, or to see if they have a relapse. If the RPR is present or is positive, this is then confirmed by a third treponemal test, often the treponemal particle agglutination test. And just as a note, often on our requisitions, we write VDRL. This is a non-treponemal test that was performed in the past in Ontario, but writing this on the requisition simply kicks off this 3-step algorithm that is done. The treatment of syphilis is also interesting. So as we mentioned, it's been around for a long time, and initial treatments were actually derived from arsenic. But with the discovery of penicillin, it was introduced as a safe and effective treatment for syphilis in the 1940s. The current treatment of syphilis still centers on penicillin, and every stage of syphilis, so whether it's primary, secondary, or tertiary syphilis, there are different treatment protocols, but many of the treatments revolve around intramuscular penicillin that's delivered weekly for 1 to 3 weeks. However, this particularly differs when it comes to neurosyphilis. If a patient is diagnosed with neurosyphilis, the recommendation is aqueous crystalline penicillin G that is delivered intravenously every 4 hours for 14 days. And most uveitis specialists, including especially documented in a poll that was done by the BJO in 2019, most uveitis specialists would agree that any vision-threatening ocular syphilis should be treated aggressively and empirically as neurosyphilis, so with 14-day course of intravenous penicillin.
And the confusing thing about this is that almost all cases of ocular syphilis are secondary syphilis. So people oftentimes will apply secondary syphilis treatment protocols for them, but obviously, especially for vision-threatening disease, you want to treat them as neurosyphilis.
Absolutely.
And also, Seema, I have a question. Mm-hmm. It's interesting that a disease that's been around for so long and had treatment for decades and decades hasn't developed any resistance to good old penicillin G. Any comments on that?
I didn't look into kind of if there is emerging resistance specifically, but looking through even, the Public Health Agency of Canada guidelines across the board. So even in areas that what you would expect would have different patterns of drug resistance, it is still recommended across the board, not only in Canada, but also in the US, in the UK, and Europe. So it is just exquisitely sensitive to penicillin. And I'm glad you mentioned that, because you often meet patients who have an allergy to penicillin, and again, uniformly across the board, at least in Canada, the US, UK, the strongly preferred practice pattern is desensitization to penicillin rather than the use of any agents, because it remains so exquisitely sensitive. The other things to consider when it comes to treating ocular syphilis is that a lumbar puncture is often recommended, especially if there are any neurologic symptoms, or this may also be recommended to follow quantitative titers in the cerebrospinal fluid. Of course, when you're getting into, following CSF, you want to involve your infectious disease specialist early. And it's important to remember that contact tracing is not just for COVID. In patients who have syphilis, there's also mandatory reporting, and you need to remind your patients that they are at risk of transmitting this infection to other people. So contact tracing becomes important in this context as well.
There's a question from the poll from Nancy Epstein, just talking about vision-threatening uveitis, whether that means posterior pole involvement. So I think what they're really trying to get at here is, if you have a patient who comes in with like an anterior uveitis, and you send off a shotgun workup and it comes back positive for low titer RPR, they're not recommending neurosyphilis protocol, because one, it's probably an incidental false positive, and two, it's non-specific for the presence of syphilis. So I would probably change the vision threatening comment for neurosyphilis protocol to any ocular uveitis that's consistent with syphilis, or specific for syphilis. So like granulomatous KPs, presence of vasculitis, presence of retinitis. It's not as much the vision threatening as much as knowing that it's caused by syphilis and not something else, not an incidental finding. And also in cases in which they're undifferentiated and there's severe vision loss, like this case. So that's, I think, probably the more important, rather than it just be vision threatening. If you think it's ocular syphilis, it needs neurosyphilis treatment. And if you're not sure, but it's vision threatening, it also needs neurosyphilis treatment.
So coming back to our case, our patient initially received 1 dose of intramuscular penicillin in the emergency room department, and there was some difficulty with follow-up, but we were able to get her back and in touch with infectious diseases, and she completed 14 days of her penicillin G treatment. This was, of course, challenged a little bit, challenging in part due to medication non-compliance compounded by her precarious housing and poor access to care, but she was able to complete the treatment. Her HIV status was also disclosed, and she was started on antiretroviral therapy. And at her last follow-up, she did have improving vitritis in both eyes. And we were able to get an OCT, which shows that her ellipsoid zone is intact here. The last vision we were able to obtain in clinic was counting fingers in the right eye and 20/80 in the left. However, she has missed some follow-up, and we recently got an email from her infectious disease specialist that she's excited to come back to the clinic to show how much more her vision has improved. So we're hopeful that she will make a full visual recovery. But I wanted to talk about why this case is so important. Why are we talking about syphilis in 2021? Well, actually, it's back and it's on the rise. In the early 2000s, we reached the nadir of syphilis incidents. And since then, across North America, rates of syphilis infection have been rapidly rising. So to give you some context, in Toronto, the rate of infection was about 1.1 per 100,000 in 2001. And by 2012, this had skyrocketed to 19.1 per 100,000 people. A really interesting study that was performed in Toronto found that many of the risk factors were unprotected sex, high rate of partner change, and the presence of STI co-infection. In particular, there was a 40% rate of HIV co-infection in the city. And whereas some people might think that this is a problem that may be confined to the downtown core or more vulnerable neighborhoods, they actually were able to document, using some pretty interesting health geography research, that there are mature syphilis outbreaks throughout the GTA. And a lot of this is actually correlated with increasing housing instability. So this is a problem that is really not only everywhere in Toronto, but the rise of syphilis has been documented in most major cities across North America and Europe. To that point, this year alone in the Canadian Journal of Ophthalmology, actually in the past 18 months or so, there have been publications from London, Ontario, British Columbia, Montreal, as well as our own group here that have documented this rising incidence of syphilis, particularly ocular syphilis across Canada. And some common themes from these papers are that the patient demographics are diverse. This affects many people from all walks of life. And some of the common challenges include delayed diagnosis, a heterogeneous presentation, making it difficult to identify syphilis, and the fact that sometimes identifying the risk factors to syphilis can involve some difficult conversations. So it may not be highlighted on the differential diagnosis quite so quickly. With that in mind, we wanted to jump into a few other cases. These were all seen within a 3-month period in the past few years, in the very recent past, by Dr. Christakis, that demonstrates how heterogeneous this disease can be. So our second case story, without further ado, was a 58-year-old family physician who presented previously healthy, who was referred from a retina specialist for consideration of Vkh in both eyes. He had presented to the retina specialist with 3 weeks of bilateral blurred vision, and initially visual acuity was actually close to 2800 in both eyes. The referring doctor had started the patient on prednisone orally at 60 milligrams. And on presentation to our clinic, you can see that the vision in the right eye was 2260, the left was 2800. And there was this large subretinal creamy white lesion involving the posterior pole and the entirety of the macula, associated with loss of the ellipsoid zone on OCT. This presentation was striking for suspicion of acute posterior placoid syphilitic chorioretinitis, which was confirmed through syphilis serology. And on further history taking, it turned out the patient was married and had actually recently had an oral ulcer that had been biopsied by his dental surgeon. The biopsy was negative, but may have presented an early oral sore associated with syphilis. And once the serology came back, the patient endorsed a recent extramarital affair with a male partner. With penicillin treatment, his vision recovered in both eyes to 2025, with reconstitution of his ellipsoid zone and resolution of the subfoveal fluid. Our second case was a patient, a 56-year-old man who presented known HIV positive with an undetectable viral load on antiretroviral therapy, who presented with concern for viral retinitis in the right eye. Presenting vision was 2200, and he presented with a moderate anterior chamber reaction and vitreous cell. Peripherally, although it's difficult to tell in this picture, there were peripheral retinal granular infiltrates. And so there was concern for viral retinitis. So he was started again on valacyclovir orally. And this patient did have an aqueous paracentesis, an anterior chamber paracentesis, that was shown to have a negative viral culture by PCR. With this result, which was not expected, a comprehensive uveitis workup was performed, and he was found to have acute ocular syphilis. And again, started on intravenous penicillin with full recovery of his vision. Next, a 45-year-old previously healthy man was referred again for a concern of viral retinitis in the left eye, presenting with 2200 vision. His exam was very concerning from the beginning, with presence of hypopyon, diffuse retinal whitening, and clear evidence of vasculitis and optic disc edema. The patient was seen on call and started immediately on valacyclovir and received actually an injection of intravitreal ganciclovir when the following day the presentation continued to progress. The PCR, however, was negative for viral infection. And again, a comprehensive uveitis workup identified an acute syphilis, ocular syphilis, as well as a new diagnosis of HIV, which was disclosed to the patient. On history, he revealed that he'd had a recent heterosexual extramarital affair, and on further questioning, had several weeks prior had a rash involving his scrotal area and hands that had self-resolved and had been essentially ignored by the patient. Again, with penicillin treatment, his visual acuity recovered, and he was started on antiretrovirals by the infectious disease team. Our fifth patient was referred, he was a young man, 35 years old, who was referred with concern for a central retinal vein occlusion. He'd had about 1 week of blurred vision, and his vision was found to be 20/60 on presentation. What tipped us off that this is not a normal case of a central retinal vein occlusion was that there was a mild vitreous cell on initial assessment. With that in mind, we performed a intravenous fluorescein angiogram, which shows this widespread diffuse vascular leakage. And it was also interesting because it, again, confirmed the presence of optociliary shunt vessels that can be seen here by the disc. Given the presence of vitreous cell, a uveitis workup was performed, which uncovered ocular syphilis, as well as a new HIV diagnosis. It was interesting because this patient had recently been seen by his family physician for new persistent knee pain and a rash, which can, of course, be associated with sexually transmitted infections as well. Finally, our last patient was a 59-year-old man who was referred for concern of optic disc pallor in both eyes. And this patient had several months of chronic vision loss to 2400. He had a significant medical history of being wheelchair bound. And actually 6 years prior, he had presented with imbalance and was found to have a frontal lobe mass. At that time, they were concerned for brain cancer and did a resection. But on pathology review, the frontal lobe mass contained spirochetes, and it was considered to be a syphilitic gamma. And the gentleman had unfortunately had some vasculitic strokes following this. He had had full treatment for syphilis at the time, although there was never any actual documented evidence of active infection serologically. It was simply the presence of spirochetes on the frontal lobe mass. And at the time of presentation to us, he had diffuse optic disc pallor, vessel attenuation, and presence of peripheral ischemia with retinal neovascularization. His only risk factor was was a remote history of unprotected intercourse and an STI for which he'd been treated as a young adult. He had been monogamous for the past 35 years. And with treatment, his retinal neovascularization stabled, but unfortunately he did not demonstrate any visual recovery. So this was felt to be a case of chronic retinal vasculitis secondary to tertiary syphilis. So in review, we've recovered multiple presentations of ocular syphilis, including a bilateral granulomatous uveitis, acute posterior placoid chorioretinitis, a pan-uveitis, necrotizing retinitis, an inflammatory retinal vein occlusion, and occlusive retinal vasculitis. And all of these patients were universally treated with 14 days of intravenous penicillin G, 3 to 4 million units every 4 hours for 14 days as described as per the neurosyphilis protocol. These cases were all seen within 3 months by a single uveitis specialist here in Toronto, which again underscores how rapidly the incidence is rising. And interestingly, all of these patients were referred with an alternate diagnosis, even in the presence of concurrent syphilis symptoms or even a previous syphilis diagnosis. And these referrals came from ophthalmologists, optometrists, family physicians, and emergency room doctors, again, underscoring how this masquerade disease can be difficult to diagnose. All but one recovered their vision following penicillin G. And again, there's a very broad patient demographic. These patients ranged in age from 30 to 60. They were both men and women and of diverse sexual orientations, relationship statuses, socioeconomic status, and were both HIV positive and negative. So what does this mean in terms of take-home points? Well, the incidence of syphilis is rapidly rising around us, and the only risk factor that you need is a history of previous sexual activity. Everybody who is sexually active is at risk of infection. Prompt treatment is necessary for visual recovery, and it's important to remember that there can be a high rate of HIV co-infection in patients with ocular syphilis. So when seeing a patient with uveitis in this era of not only a COVID epidemic, but a syphilis epidemic, it's important to consider syphilis in every patient who presents with a new or refractory ocular inflammation, and to perform syphilis testing early. So it should be included in every uveitis workup, but should also be considered if you're faced with a patient with atypical optic neuritis or retinitis. If you're truly concerned for the presence of syphilis but receive a negative serology, consider repeating the blood work in 2 to 3 weeks to identify patients who are at risk of early seroconversion, and consider your concurrent HIV testing. And finally, don't hesitate to refer early to uveitis and infectious disease specialists who can guide you through therapy and ensure that rapid penicillin therapy is initiated. And with that, I just wanted to say thank you and open the floor to any questions. And just want to say thank you to Dr. Christakis for not only helping me put this presentation together, but also for his mentorship in reviewing that case series with him.
Well, that was a great review, Seema, and we'll open the floor to some questions. A big question that we oftentimes get is in terms of when to work up patients. I think what you said in that last slide about when in any person who has risk factors for syphilis, or in any kind of vision-threatening disease where you're not sure what's going on, that's definitely worth getting syphilis serologies on. In terms of just kind of the general workup for uveitis, so for a first episode, oftentimes we don't work them up unless it's bilateral or severe disease. Second episodes oftentimes require workup just to ensure that there's nothing systemic going on. Granulomatous uveitis tend to have a much higher incidence of both infectious or inflammatory systemic association. So I work up everyone who has granulomatous uveitis, even if it is the first episode. And then the question that Alex had about anterior chamber taps for viral PCR, granulomatous cases is that are severe, I think is worth considering. I personally do an anterior chamber tap on everyone who presents with a primary hypertensive uveitis because they have a very high rate of viral etiologies. And the rates have been published by the group with Nupra Bakshi, Larissa Dursko, and Alex Kaplan as being up to 35 to 40% yield for taps for people with hypertensive primary uveitis. And the reason why I say hypertensive primary uveitis is oftentimes people come referred in with high pressures, and it becomes very difficult to know whether the pressure is elevated due to a primary cause like trabeculitis, or whether it's due to a secondary cause like steroid response. If somebody's been on topical corticosteroids for a while, oftentimes they develop a steroid response. And it's for that reason that I think it's prudent to perform a viral tap if possible on primary hypertensive uveitis, because what happens is people come in, they have a high pressure, you start them on corticosteroids, they oftentimes will get better, and then a month later their pressure goes back up, and you're not sure, is this a recurrence of the primary process where there's increased trabeculitis from inflammation, or is it because this patient's developing a steroid response, and you're kind of caught in between a rock and a hard place as a result of that. So it's sometimes difficult to get these taps unless you're through a hospital setting, but through referrals to the academic downtown core, you can get access to these to this testing. So we should move on to Ryan's talk, which is a single case, so it should be a little bit quicker and give some time for questions at the end.
All right, great. Thank you. Thanks for the opportunity to speak today, and thanks to Dr. Christakis as well for providing this very interesting case. So we'll jump right into things. So for the case, we have a 21-year-old male who presented with severe headache for 1 week, soon followed by red eye, and then also developing blurred vision for around 3 days. His past medical history, ocular history, medications, and social history were all largely unremarkable. He was seen by the ophthalmology team on call, and his vision was 20/80 in the right eye, 2200 in the left, normal pressures and no RAPD. He had a AC reaction in both eyes with +1 cell, but no KP were noted. And he also had bilateral retinal detachments with multifocal patches of subretinal fluid, but no breaks were seen. So here we have 2 fundus photos from presentation of the right and the left eye. You can first appreciate that there's a clear media with no evidence of vitritis or haze. On the right eye, there's a region of subretinal fluid just superior to the inferior arcade and possibly tracking up into the macula. Supratemporally to the disc, there's fairly well demarcated regions of subretinal whitening, which may also represent fluid. And most of the findings are concentrated to the posterior pole. On the left eye, there are similar findings, and they extend a bit more into the periphery. There's really nothing that strikes you as a vasculitic process or really an infectious process, at least at this stage. A very comprehensive review of systems was done, all negative. There was no history of genital ulcers or STD history. He had no constitutional symptoms. His weight had been stable at 120 kilograms. And his ethnicity was 75% European, 25% Moroccan, but he was born and raised in Canada and little time spent outside of the country. So this brings us to our first poll question. Based on this initial presentation, what do you think would be the most likely etiology? We have an idiopathic uveal effusion, Vogt-Koyanagi-Harada disease, an intraocular or CNS lymphoma, or a CSR type picture. So again, young male, mild AC reaction, and bilateral serous retinal detachments. Perfect. So we have a pretty overwhelming response from the audience that it's most in keeping with the VKH type process. And that's also what was thought by the team on call. And therefore, the patient was started on Pred Forte in both eyes, QID, prednisone 60 milligrams daily, and pantoprazole 40 milligrams as well. And we expect VKH to be very responsive to steroids. However, 1 week into the treatment course, the young man represented with worsening headache, decreased vision, and more red eye despite being on oral steroids. His AC reaction was now 3+ in the right eye, 4+ in the left. He had 2+ vitreous cell and extensive bullous serous retinal detachments with subretinal fluid. His vision had decreased in both eyes, where he was only counting fingers now in the left eye. Visual fields show diffusely depressed vision in both eyes. And we can see on his OCT, he has these large bullous serous retinal detachments in the macula. And characteristic here are interretinal RPE pillars or septations. So now what would you do here? Brings us to our second poll question. Do you continue management as some progression is expected early in the treatment course? Do you immediately increase the steroid dosing? Do you switch to an immunosuppressive therapy in consultation with rheumatology? Or do you review the diagnosis given its atypical treatment response? Okay, great. So around 68% would review the diagnosis and 14% would continue the same management. So here we have what looks like a typical presentation for VKH, but a very atypical response to steroid treatment. So in a situation like this, it's important to kind of step back and review the diagnosis. So briefly, what is VKH? So it initially was treated as two separate syndromes, Vogt-Koyanagi and also Harada disease, but there was a lot of overlap, and in the 1930s, these two were combined. It's a multisystemic granulomatous autoimmune inflammation, and it largely targets melanocyte-rich tissue. It affects people mainly in the 2nd to 5th decades of life. And its incidence and sex predilection really depend on where you're located in the world. In Japan, it's more common with 7 to 9% of uveitis cases, and it skews more male. Whereas in North America, it's more rare with 1 to 4% of cases, and it skews more female. It does affect those who are more darkly pigmented, such as Asian and Middle Eastern populations. So that makes it rare amongst Caucasians, but it's also rare amongst sub-Saharan Africans. So it's not only dependent on the amount of skin pigmentation, but there's also genetic predisposition, which I'll touch on later. Reviewing the diagnostic criteria, there's quite a few. First is that there should be no penetrating ocular trauma or surgery preceding the initial uveitis. Sympathetic ophthalmia is on the differential diagnosis. There's no clinical or laboratory evidence of other ocular disease entities. When we get into number 3, the criteria get a little more complex, and it depends on the stage of the disease with bilateral ocular involvement. Early on, you can have diffuse choroiditis that includes focal areas of subretinal fluid or bullous exudative retinal detachments. If the findings are more equivocal, you can look at imaging. For instance, on fluoresceint angiography, pinpoint leakage is quite characteristic, as well as pooling within the subretinal fluid. On ultrasound, there can be diffuse choroidal thickening, but no posterior scleritis. Late manifestations include ocular depigmentation, such as the sunset glow fundus, or chorioretinal depigmented scars with RPE clumping and migration. There's neurological or auditory findings that include meningismus, which has fever, headache, neck stiffness, as well as back stiffness, tinnitus, and if a lumbar puncture is done, CSF piocytosis. Now, technically, headache alone does not meet the criteria for meningismus, so it's important to elicit some of these other neurological findings on history. And then finally, you can have integumentary findings such as alopecia, scoliosis, and vitiligo. If you have all 5 criteria present, that means you have complete VKH. Incomplete is criteria 1 to 3 with either 4 or 5 present. And probable or isolated ocular disease is present if you have the first 3 criteria. So what's on the differential diagnosis for VKH? So again, you can have sympathetic ophthalmia. Then you have to consider infectious etiologies such as syphilis or TB, non-infectious choroiditis, so the white dot syndromes, other inflammatory disorders such as a serous scleritis or sarcoidosis, non-inflammatory central serous retinopathy is an important differential to consider with VKH or uveal effusion syndrome. And you should always consider Masquerade syndromes in these cases, such as lymphoma. Some characteristic features on imaging. So we have fluorescein angiography. During the acute stage of the disease, you can have patchy fluorescence from the choroidal circulation. And there can also be delayed choroidal perfusion in the posterior pole. Very characteristic of VKH are pinpoint areas of leakage at the level of the RPE. And these can, over time, coalesce into the subretinal space if you have serous retinal detachments. So in our patient here, there's a few areas of maybe pinpoint leakage, but there's really not that many, not as much as you might expect in VKH. There have been studies that looked at the importance of pinpoint peripapillary hyperfluorescence as a prognostic factor in VKH, where the absence of such a sign really suggests that the disease is no longer only in the early stages and may require more aggressive treatment and more prolonged treatment as well to deal with the initial presentation and also prevent future recurrences. If we look at fundus autofluorescence, in the acute phase, you can have mild and uniform hyperautofluorescence in the macula, corresponding to areas of the serous retinal detachments. The focal serous retinal detachments are often shallow and can have a cloverleaf type pattern in the posterior pole, and over time, these may coalesce. On OCT of our young man here, we have bilateral serous retinal detachments in the macula. And these retinal pillars or fibrinous subretinal septations that connect the RPE to the inner retina are quite characteristic of VKH. In addition, on the OCT, you can have intraretinal edema, RPE undulation, or choroidal folds. So in reviewing the differential, the presentation is mostly in keeping with VKH, but it's, again, quite unusual to have a poor response to steroids. So we need to consider other etiologies. Could it be infectious? Well, there's no choroidal retinitis, no systemic symptoms, and no infectious history, such as STDs, cold sores, or TB risk factors. Initial workup was negative in terms of blood work, as well as chest x-ray, with no signs of active or latent TB and no hilar adenopathy. Could it be CSR? Well, there's some distinguishing features between CSR and VKH. The presence of inflammatory cells will be seen in VKH, which is what our patient had. Optic disc hyperemia as well. On FA, you can have disc leakage in VKH, whereas a more multifocal leakage in CSR. On the OCT, in CSR, you can have PEDs, whereas in VKH, these subretinal septa and RPE folds are more characteristic. And then finally, could it be a Masquerade syndrome? So to rule that out, urgent MRI was ordered. And on the MRI, you can see choroidal thickening and even the changes within the retina itself. But there was no evidence of any malignancy present. So finally, this brings us to a final poll question. Now, what is your approach to management? We're more confident in our diagnosis of VKH. So again, do you continue treatment, continue current management? Do you review the oral steroid dosing? Do you do a local steroid injection, or now switching immunosuppressive therapy that you think the patient has failed oral steroids? Okay, great. So we have a bit more of a split here where almost 50% of people would switch to an immunosuppressive therapy, and a quarter of people would review the oral steroid dosing. So our first approach here was to review the oral steroid dosing. Now, recall that the patient's weight was 120 kilograms, but they were on 60 milligrams daily of prednisone. For VKH, the standard oral dosing is 1 to 1.5 milligrams per kilogram per day early in the disease course. With severe inflammation, such as this case, you can use 1 gram per day of a pulse IV steroid. And that was done for 3 days in this case. If they're intolerant of systemics, you can use a intravitreal. And you want to taper very slowly, at least over 3 to 6 months, according to the clinical response. So on the pulse, and then transitioning to 120 milligrams per day, the patient did have good response. Even in a few days, there was decrease in the serous retinal detachments from day 7 to day 9. However, despite this initial improvement, he presented on day 16 with progressively worsening vision and bullous serous retinal detachments in both eyes. You can see it doesn't only involve the inferior regions, but it's almost getting to 360 degrees. And the retina is also almost kissing in some areas. And with a prolonged macula off, there's a risk of photoreceptor degeneration and also poor visual prognosis. So intravitreal treatment was done, and the decision was made to proceed with a surgical drainage, given the patient with now light perception and hand motion.
So this is a very tough case. You know, you have a young 21-year-old who now is LP and hand motion with near total RDs in both eyes. It's always important in these cases to take a step back and look at every part of the treatment. And at this point, I was still convinced of the diagnosis based on the fact that he did show some initial improvement with the IV steroids, but when he was transitioned to oral steroids, he worsened again, even though it was 120 milligrams. This guy was about is 6'5", 120 kilos, a very large guy. And so the thought was that maybe he was inadequately dosed. This is a very unusual case to have such severe disease. The fact that he had ongoing 2 to 3 plus cells in the anterior chambers, another kind of marker. It's a surrogate marker of the degree of the immune response and inflammation. So at this point, you know, he's got, you know, LP and hand motion. And so, you know, the thought was that anatomically, if you leave somebody who's macula, he's been macula off now for about 8 days from that initial time when we switched into oral steroids from those OCTs. And so you worry about anatomic worsening, just like a rhegmatogenous detachment if you leave them too long. So proceeded with injecting the first eye going to surgery with, didn't receive an injection, but the surgery was done one eye at a time. But intravitreal triessence was injected in the second eye as a kind of temporizing measure until the second surgery could be done. But Ryan will go through kind of some of the implications of surgery in these cases, which is very rarely done.
Yeah, so for the approach to the surgical drainage, initially a transscleral approach was attempted with a 27 gauge needle. And the goal was to minimize disturbing the vitreous. But unfortunately, the serous retinal detachments were very loculated. So only a small amount of fluid could be aspirated. So there was some reattachment using the transscleral approach, but ultimately there wasn't really enough. And the decision was made to proceed with a perisplanal vitrectomy at that stage. The vitreous was sent for cytology. It's a good opportunity just to see if there's anything that's being missed in terms of a differential. So we had cytology, flow cytometry, and microbiology that all came back normal. An air fluid exchange was done with some partial reattachment. But then retinotomies were ultimately done to better drain the loculated subretinal fluid. With the retinotomy comes a risk of a rhegmatogenous retinal detachment. So laser was applied around the holes, and the region was well lasered with 800 to 1,000 spots. Oil was used to maintain tamponade, so Celeron or Denzeron, and subtenon Kenalog was used as well.
And it's really important, obviously, the placement of oil, because you're creating retinotomies, and you have somebody with an exudative process who may get exudation post-op, and it would be very, very high risk for converting, an exudative detachment now to a rhegmatogenous detachment. So having a good fill of oil was very important to prevent reaccumulation of subretinal fluid.
So there again was some improvement at week 3. Post-operative, the retina was flat, but then there was an urgent patient call with acute decreased vision in the left eye. The patient was now no light perception with a pressure of 55. And what was found on assessment was there was migration of the Denzeron with 11 clock hours of iris bombé in the left eye. He was placed on maximum medical therapy, as well as Diamox with removal of silicone oil in the AC, with some initial improvement in vision and also intraocular pressure. By week 4, the vision had improved, pressure had improved, the cornea was more clear. He did have a hyperopic shift given the silicone oil, and consultation was made to low vision to aid with refraction and aids this patient could have. At this point, he was counting fingers in both eyes. And things looked good. So he was on tapering his prednisone. Now he was at 100 milligrams, and also continuing Durezol and Simbrinza for pressure management. By month 2, pressure had again increased, and he had the 40% Denzeron bubble in the AC in the left eye. Pressure was now 39 in the right and 41 in the left. And this was thought to be due to a combination of factors, including steroid response. He had been on Durezol, intravitreal treatment, and subtenon Kenalog as well. Predisposition for pigment dispersion with transillumination defects and Krukenberg spindles, and also the presence of silicone oil, such Denzeron. So we increased. Oh.
So I was just going to mention, so when he initially called in saying he was NLP with a migration of Denzeron into the AC, that's first of all extremely unusual in a phakic patient, but obviously there's some way that this oil got around the zonules and into the AC. Anyone that's removed Denzeron from the anterior chamber, it's extremely difficult to remove due to the fact that it's very dense. So what I did was I used a 25 gauge, and I made a very short paracentesis in order to burp out as much as I could. And obviously there was a leak after, so I put a bandage contact lens on in order to stop the leak. But I couldn't remove more than about 60% of it. It was 100% fill of the AC with Denzeron, but I was able to get out about 60% of it. So he was left with a 40% Denzeron bubble in the AC, which he actually tolerated very well. Until he started to develop some corneal edema in that eye as a result of Denzeron touch. I guess not enough endothelial pump function in that area, and so I took him back to the OR to wash out that Denzeron. And the increased eye pressure was thought to be as a result of steroid response rather than related to the Denzeron, given the fact that it was in both eyes.
And at this stage, glaucoma was also involved in his care, just to see, just for the consideration of other management, such as a gap procedure, cyclophotocoagulation, preventative LPI. But again, just because it was due to more of the steroid response and there was active inflammation going on, he just maintained on the topical therapy and diet. At month 3, his retinas were stable, flat, improved vision on 4 IOP classes in the Diamox. He was tapered down to 20 milligram daily of prednisone, and in consultation with rheumatology, was now on Cellcept 1 gram BID, with some vision improvement and stable pressures. However, later that month, he was found to have increased serous retinal detachment and choroidal thickening that consistent with recurrence. So his prednisone was increased, Cellcept was increased, and consideration was also given to switch immunosuppressant agent. Currently, he's doing quite well. with vision of 20/25 in the right eye, 20/50 in the left eye. He's on 70 milligrams daily of prednisone and will soon transition to Remicade. So I know we're getting close to time here, so I'll go through the last few slides a little bit quickly. Just in terms of pathophysiology of VKH, the most accepted mechanism involves an autoimmune process with a presumed viral trigger. In PCR of vitreous from VKH patients, there have been found herpes viridae virus. And it's a cell-mediated process with a genetic component where HLA-DR4 positive patients among Japanese and DR1 and DR4 among Hispanic patients. You'll find a non-necrotizing granulomatous inflammation, presence of Dale and Fuchs nodules, and multinucleated China cells on histology. It's a multiphasic disease. So in the prodromal stage, it largely mimics a viral infection. Precedes the ocular inflammation and can last 1 to 2 weeks with fever, headache, tinnitus, and those other neurological symptoms. If an LP is done, there can be pleocytosis, and even on imaging, there can be parenchymal lesions. In the acute uveitic stage, which is where we saw this patient, there's often reduced visual acuity in both eyes. In 94% of cases, there'll be bilateral involvement within 2 weeks. You can have a diffusely thickened choroid. Some of the images shown here are just hyperemia, a multifocal choroiditis, multiple regions of serous retinal detachment, as well as choroidal folds. And again, eventually this will likely evolve to a granulomatous panuveitis. In the convalescent stage, it happens about 3 to 4 months later, but can last years. There's depigmentation, so you have the sunset glow fundus, vitiligo, alopecia, poliosis, perilimbal depigmentation. It's rarely seen outside of the Japanese population, and also hypopigmented chorioretinal scarring. In the chronic phase of the disease, there's repeated granulomatous anterior uveitis, and a little bit less common to have posterior involvement with PSC cataracts, glaucoma, CNV, and subretinal fibrosis. In terms of treatment, the mainstay is aggressive corticosteroid treatment early in the disease process. It involves prednisone or a pulse of IV methylprednisolone if there's a lot of inflammation. You can use antimetabolites such as Celsat, which is done in this case. It's important to monitor for infection if patients are on this agent. Calcineurin inhibitors and biological agents such as Remicade, which is what the patient will transition to, can also be used. If you're considering an agent like this, it's important to first test for any signs of latent TB and monitor for lymphoproliferative disease. And finally, in terms of prognosis, it's quite good, with about 60% of patients having a visual acuity of 20/40 or better at the end of the disease course. Some prognostic factors involve treatment. So early initiation of treatment gives less persistent inflammation. Optimal dosing is important. Patients treated with low-dose corticosteroids in the acute phase were more likely to have persistent inflammation. And also the duration of treatment. If it's shorter than 3 to 6 months, those are associated with a poor visual prognosis. Patient factors, the presence of positive HLA factors. And age of onset is a little more controversial. Some studies have a younger age of onset, having worse prognosis, others an older age of onset. And finally, there's disease stack. Oh.
Okay, I think we're getting the hook here in the so it's 8:35. But just to I can kind of just give the final take home points for this is really, when you see a patient, it looks like a duck, quacks like a duck. Always think of a unusual presentation of a common illness rather than something that is a zebra. So in this particular case, he had all the features of VKH. He wasn't responding as well, probably because he was initially underdosed and because he had very severe disease. You have to kind of stick with your diagnosis and follow these people very, very, very closely, because they do run into secondary issues. Like this guy had pretty much every possible complication in terms of secondary issues, but with very close care and multidisciplinary care, he was able to achieve 20/25 and 20/50 vision, considering he had bilateral, almost total RDs and a vision of LP and hand motion. It's pretty amazing how well this young gentleman has done. So as Ryan said, you want to treat them early. You want to follow them closely, and you want to give them a course of oral steroids starting at 1 milligram per kilo per day with a taper over 3 to 6 months, depending on their clinical course. In terms of secondary immunosuppression, I know in some of the polls, people were recommending doing the secondary immunosuppression early. Unfortunately, a lot of these have a very long course to actually get a response. So, switching somebody to Cellcept or methotrexate is not going to have nearly as much of a response as steroids. So really steroids are your initial option to deal with the acute phase. So you want to make sure whether it's intravitreal, subtenons, oral, IV, you have to get their disease under control with steroids first. And once they're controlled under steroids, then you can kind of proceed to finding something long-term in terms of steroid-sparing immunosuppression. All right, that was a great presentation, Ryan. Thank you, everyone. Sorry, I ran a couple minutes over. But if anybody has any questions, they can always send me an email or reach out to either Ryan or Seema.
Thanks, everyone. Wonderful presentations. We're going to end now to allow residency to start on time, but that was excellent and very important work you do. Those are tough cases to manage. So thank you all.
Thank you, guys. Have a good weekend.
Have a good weekend.